Hi, and welcome to the AAPM Cares discussion of fetal shielding. I am Rebecca Marsh, a medical physicist from Colorado. Along with Dr. Sarah McKenney, I helped to prepare this education module for the Cares Committee. The objectives of this module are to learn about the effects of ionizing radiation on a fetus, to understand how much radiation a fetus is exposed to when the mother has an imaging exam, and to understand the benefits and risks of fetal shielding. Throughout this talk, fetal dose will be described as whole body dose using units of milligray. There are two general types of risks to a fetus that we will discuss here. The first includes abnormalities in the developing embryo or fetus that results in either pregnancy loss, also sometimes called spontaneous abortion, or a congenital disability. Congenital disability includes physical abnormalities that are present at birth and any associated intellectual disability. In the United States, the baseline risk, or the risk due to random developmental processes during pregnancy, is about 20% for pregnancy loss and about 3 to 5% for congenital disability. Studies have shown that exposure to large amounts of radiation increases the risk of pregnancy loss or congenital disability. It's important to note, however, that these effects have only been seen when a fetus is exposed to an acute dose of at least 200 milligray. This means a one-time radiation exposure of 200 milligray. The magnitude of the increased risk depends on the stage of pregnancy at the time of exposure. These radiation effects fall into the category of tissue reactions, also known as deterministic effects. The second type of risk from radiation exposure describes whether or not someone who was exposed to radiation in utero, or when they were a fetus, has an increased risk of developing cancer. Here the data are a lot less clear. As the NCRP states in its Report 174, the association between fetal radiation exposure and cancer risk has been debated for over 60 years because research has yielded conflicting results about what happens when a fetus is exposed to small amounts of radiation. It's important to note that here, a small amount of radiation refers to any acute exposure below 100 milligray. Some studies have shown that when a fetus is exposed to radiation, the child has an increased risk of developing cancer. Other studies have shown that there's no risk, or even that there's a decreased risk of developing cancer when a fetus is exposed to small amounts of radiation. Still, other studies have suggested an increased risk of developing leukemia, but a decreased risk of solid cancers. We know more about what happens when a fetus is exposed to larger amounts of radiation. There is strong evidence that when a fetus is exposed to an acute dose above 500 milligray, the child has a measurable increased risk of developing cancer. At acute doses below 100 milligray, however, the risk to the fetus is either very small and may even be non-existent. So let's talk a little bit about fetal doses in medical imaging. The exact dose to a fetus for any specific exam depends on the amount and energy of radiation used. Among other things, these are reflected by the MAS, KV, and beam filtration. Dose to the fetus also depends on where the fetus is relative to the source of radiation. Fetal shielding is used with the intention of decreasing the dose, and therefore risk, to a fetus during an X-ray-based exam of the mother. This includes mammography, dental X-ray, radiography, fluoroscopy, and CT. We will discuss the role of fetal shielding in each of these modalities, including the location of the fetus relative to the X-ray source and the approximate fetal dose when shielding is not used. In all X-ray-based imaging, primary X-rays travel from the X-ray tube and through the patient. Some X-rays that pass through the patient will scatter in a direction that's different from that of the primary beam. The energy of these scattered X-rays is smaller than that of the primary X-rays. Since most of the primary X-rays are absorbed by the patient, there are also a lot fewer scattered X-rays than primary X-rays. All of the primary X-rays are absorbed by the detector or the patient's anatomy that is in the image. Any anatomy that is outside the imaging field of view is only exposed to scatter radiation that originates inside the patient. This is a critically important point in understanding the amount of protection that patient shielding can provide. Parts of the patient's body that are not in the image are not exposed to primary X-rays. They are only exposed to scattered X-rays that have been produced in the patient's body. In mammographic imaging, the fetus is not exposed to any of the primary X-ray beam, since the beam is entirely intercepted by the image detector before it would even reach the fetus. The fetus may be exposed to radiation that has undergone one or more scattering events within the mother. The amount of scattered radiation that reaches the fetus is very, very small, however, below a fraction of a milligray, and usually cannot even be measured. The same is true for dental imaging. All of the primary X-rays are absorbed by either the detector or the patient's anatomy that is in the image. A fetus is only exposed to scattered X-rays that are produced inside the patient. In radiography, there are two possible scenarios, so things are a little bit different. Either the fetus is outside the imaging field of view, in other words, the fetus is not in the image, or the fetus is inside the imaging field of view. It is in the image. The first scenario, where the fetus is outside the imaging field of view, describes the majority of radiographs, including imaging of any extremity, the cervical and thoracic spine, skull, or chest. Since the fetus is not exposed to the primary X-ray beam, the fetal dose is very, very low, less than a couple thousandths of a milligray. For a radiograph of the lumbar spine, abdomen, or pelvis, the fetus is inside the imaging field of view and is exposed to some of the primary X-ray beam. In this case, the dose to the fetus is a little bit higher, about 1 milligray for a lumbar spine exam that consists of AP and lateral views, and about 1 to 3 milligray for a single image of the abdomen and or pelvis. The exact fetal dose, as I mentioned before, will depend on the protocol used for the exam, MAS, KV, filtration, etc., and how much of the mother's tissue is between the fetus and the X-ray source. What we can see from this, however, is that a fetus receives the most radiation from an X-ray exam of the abdomen and or pelvis. But even here, the dose is much, much lower than what is known to cause fetal harm. In fluoroscopy, the situation is a little bit more complicated. Fluoroscopy exams, even of the same type, can vary substantially in total imaging time. Fluoroscopy also will often include imaging of different anatomy at different points in the procedure, so the fetus may be in the imaging field of view for some or all of the exam. When the fetus is outside the imaging field of view, however, fetal dose is very low. If the fetus is in the imaging field of view, fetal doses can become very high, especially with longer imaging times. CT imaging is similar to radiography in the sense that the fetus is either outside or inside the imaging field of view. When the fetus is outside the imaging field of view, they are not exposed to the primary X-ray beam, and their radiation exposure comes from internal scatter generated within the mother. This means that for any CT exam that does not include the fetus in the imaging field of view, fetal doses are fairly low. Even for a CT scan of the chest, the fetal dose is typically below 1 milligray. When the fetus is in the imaging field of view, again, when imaging the abdomen and or pelvis, the fetal dose can be higher. For a CTA exam of the pelvis, fetal dose is often around 20 milligray. So let's look at the effect that shielding has on reducing dose to a fetus. In mammography and dental X-ray, a fetal shield provides zero benefit because the fetal dose is already so low as to not be measurable. When the fetus is outside the imaging field of view in radiography, fluoroscopy, or CT, the use of fetal shielding results in only a very modest reduction in fetal dose. One study showed that for a CTPA exam, using fetal shielding decreases dose to the fetus from 0.17 milligray to 0.15 milligray. In other words, using fetal shielding reduced dose to the fetus by 0.02 milligray. This was the measured fetal dose just below the scan range, with a shield placed 1 centimeter below the scan field of view. When the lead shield was placed a bit lower, 5 centimeters below the scan field of view, there's no dose savings at all. So this gives us an idea of what the benefit is of using fetal shielding. It's important to realize, however, that the use of fetal shielding also introduces additional risk. This risk comes in a couple of different forms. The first is shown here, where the shield covers relevant anatomy. In this case, the image will have to be redone. These are examples from fluoroscopy exams where the lead shield, meant to protect the patient or fetus, ended up in the imaging field of view. In both cases, the automatic brightness control component of the fluoroscopy system increased the X-ray tube output to try and see through the lead shield. This resulted in very poor image quality and increased dose to any areas not covered by the lead shield. The image on the left has a yellow circle that indicates where the automatic brightness control sensor is on that system. The exact location of these sensors varies from one fluoroscopy system to the next. Shields can be particularly problematic in fluoroscopic imaging, partly because all fluoroscopy systems use automatic brightness control, and partly because the operator may end up having to image parts of the anatomy that they had not originally intended to image, or image from different angles. This makes it especially challenging to set up the patient and shield and not have it enter the imaging field of view. In this example from a CT scan, patient shielding that was in the imaging field of view caused severe imaging artifacts in the CT image. Lead shielding can also be problematic when it enters the field of view, even if it's only during the scout or localizer scan. Here, the lead shield is visible in the scout image, but was moved out of the imaging field of view before the diagnostic scan. There are no image artifacts, but the automatic tube current modulation saw the lead in the localizer and increased the MAS over this portion of the scan. The MAS over the anatomy covered by lead in the localizer was twice that of the nearby slices that were not covered by lead. As we discussed earlier, fetal shielding has been used with the intention of reducing the risk to the fetus during an imaging exam of the mother. We've discussed the amount of dose reduction that we get from using fetal shielding. We can now get an idea of what this means in terms of risk reduction. I mentioned earlier that it is unclear exactly what effect there is to a fetus after exposure to less than 100 milligray of radiation. But in this example, I'm going to take a very conservative approach. I want to emphasize here that this is a hypothetical case and not based on actual data. Some studies suggest that exposing a fetus to 100 milligray increases the risk of developing cancer by a factor of 2. This is again a very conservative estimate, meaning that we're likely overestimating the risk. If we then assume that the relationship between fetal dose and risk is linear, another conservative assumption, then we can get an idea of what the maximum benefit might be from the dose reduction provided by patient shielding. This table shows fetal dose, the associated risk of developing childhood cancer, and the associated risk of not developing childhood cancer. I included the column on the right because looking at risk in this way can emphasize that even at higher radiation exposures, the risk of developing childhood cancer is still very low. The baseline incidence of childhood cancer, even with no radiation exposure above background, is about 2.26%. Another way of looking at this is that 99.74% of people will not develop a childhood cancer. In this hypothetical example, exposure to 0.02 milligray of radiation increases risk slightly, but the chance of not developing cancer is still very, very high. So let's consider the data I showed earlier, where placing a lead shield just outside the imaging field of view for a CTPA exam decreased fetal dose by 0.02 milligray. We have to weigh this small dose reduction in the very, very small change in hypothetical risk of developing cancer with the known risks introduced by using fetal shielding. In summary, the radiation that a fetus is exposed to during an X-ray-based imaging exam of the mother is too low to cause pregnancy loss or congenital abnormalities. Increased cancer risk is either non-existent or very, very low. The exception to both of these statements, however, is for long and or complicated fluoroscopy procedures where fetal doses can be much higher if the fetus is in the imaging field of view for prolonged periods of time. However, even for long fluoroscopy procedures, fetal shielding should not be used. Outside the imaging field of view, the shield provides negligible dose reduction to the fetus. Any risk to the fetus only occurs when the fetus is in the imaging field of view, where using a shield would be inappropriate. We've also discussed the risks associated with fetal shielding. These include negative effects on automatic exposure control systems, which lead to poor image quality and increased radiation output, and also that shields may cover relevant anatomy. This leads to repeated exams and poor exam efficacy. If a shield covers anatomy that we need to see, then we've defeated the purpose of doing the imaging exam in the first place. Lastly, continuing to use fetal shielding when it provides no measurable health benefit reinforces false information about radiation risk. This is a disservice to our patients. It makes it difficult for patients to make truly informed decisions about their health care. Overestimating the harm that is caused by radiation has its own risks. It can cause a delay, compromise, or denial of adequate medical care for pregnant patients, which can lead to a missed or delayed diagnosis. It can also cause unnecessary parental anxiety. In summary, fetal shielding provides only a small absolute decrease in fetal dose, less than a milligray, and often much less than a milligray. The benefit from this potential decrease in fetal dose is much, much smaller than the risks associated with fetal shielding. I've included some references, and here's some contact information. The CARES Committee is committed to ongoing meaningful conversations. Please feel free to reach out to us with any questions or comments that you have. Thank you.